Okay, so we're going to talk about twin pregnancy imaging. This came up as request from a number of sonographers. And I have, as an obstetrician, I have lots of twins in my practice. So I definitely have lots of experience from both sides, and even triplets and even quadruplets. How exciting. Okay, I have no disclosures. So we'll just start with some definitions. So obviously when we say multiple gestation, it's a pregnancy carrying more than one fetus. I once had a lovely resident who, a DI resident, when I'd said, oh yeah, she's a multip, thought I meant that she was multiple gestation. No, so that is different. Twins obviously are pretty common. I'm sure you know somebody who does have twins, especially more so with in vitro fertilization and ART. Triplets a little bit less common, and quadruplets 1 in 700,000, and quints 1 in 63 million. So you're probably not going to see those. I'm not going to talk about the maternal risk of multiples. That's something that is the other side of my life or professional life, but definitely, it is important for us to have a diagnosis of multiples, and that they are referred to the appropriate subspecialist, because there is higher risk of things like postpartum hemorrhage, preeclampsia, cesarean section, and diabetes. But why do we use ultrasound in multiple gestations? And there's a couple of these, and I've bolded the top: determination of chronicity. And this was alluded to with Dr. Chandra's talk, but definitely we're going to be focusing a lot on that. Confirmation of gestational age. So yeah, we know that first trimester ultrasound greater than 10 millimeter CRL in Canada is considered the standard of care for determining gestational age. More so important than multiples, because we often have early births of multiples, and therefore knowing how, if we have a baby that's at the threshold of viability, to be have a very accurate gestational age, but also because we do deliver these babies earlier. Diagnosis of anomalies as per singletons, but when it comes to monochorionic twins, they're a higher risk of that. Higher risk of preterm birth. Yes, that's probably our biggest issue with twins and triplets and more. So we use cervical length to assess risk. And then later on in pregnancy, assessment of growth, amniotic fluid, and fetal well-being. And then also it can be used to help us manage and have delivery planning as well. Okay, so even though I know we probably all use A and B based on ISAWOG, we really should be labeling the fetuses 1 and 2. And the designation of number 1 is based on the gestational sac, which is closest to the cervix, which should be able to be, determined by the late first trimester. And once we have designated the fetus number 1 or number 2, you can't change it. So even if number 1 is no longer the first fetus, that fetus is still number 1, and that has to be clearly put on the ultrasound report. And why that's important is, what if your fetus 1 is not growing as well as the other baby? Then you can't compare growth if it's 2 separate babies or you're mixing them up. The caveat being is for mono twins, monoamniotic twins, that's very difficult, but again, that's not going to be something you'll see very often. And ultrasound reports should give details which help confirm and keep on track which baby is which. So for example, this is what I would put in a report: a live dichorionic twin pregnancy is identified. Fetus 1 is presenting breech on the maternal right, has an anterior placenta, and appears female. So for example, so that if they do switch positions, that we'll be able to keep track. Okay, this is a concept that's very confusing to people, and I will try and keep it as simple as possible, as per Janie and her Albert Einstein analogies, because they are different, and but still important to know. But for the sake of pregnancy management, we don't really care so much about zygosity. We care about chorionicity. But I'll just explain a little bit. So zygosity is the genetic classification based on conception. So I realize my little screen thing might be in the way, so I apologize if it is. With monozygotic twins, you have one egg, one sperm, and they split. And sometimes they split early enough that you end up with two placentas, but the majority of them have one placenta. So monozygotic twins are identical twins. So dizygotic twins, two eggs, two sperm, always end up with two placentas and their own amniotic sac. And so those are the fraternal twins. But do recall, so as I said, sometimes you'll have diamniotic, dichorionic twins, which are actually identical, and you probably won't know that. And from a pregnancy management perspective, it doesn't really matter. But, if you have, two female fetuses and when they come out, even though they had their own placentas and they look alike, then there is a 1 out of 7 chance that they actually are identical. And the only way of knowing that is genetic testing or blood testing. Okay, so back to that for pregnancy managed, chorionicity and amnionicity are what's important, not. And can you guys still hear me? It suddenly said I was muted.
Yes.
TT, yeah, good. Okay, excellent. Okay, for there we go. So I want to talk about dichorionic diamniotic twins. And when I discuss this with my patients, because I frequently, when I see them for their first obstetrical consult, even though they've had multiple ultrasounds, no one has really sort of sat down and explained twins. So dichorionic diamniotic, it's basically like, think of a bedroom. There's 2 beds in that bedroom. They can be separated by a little light stand. And both of those kids are in their beds and they have their own blankets. Of course, highest risk for these twins are premature labor, so that needs to be monitored for, and that they want to exit sooner than they're supposed to. We all know what that's like, those of us who are parents. And then monochorionic diamniotic, think of it like 2 babies in a bed, but they have their own side, or 2 kids in a bed. They have their own side of the bed. They each have their own blanket, and they're pretty much separate, but they are sharing a bed. And sometimes one baby may sort of try and hog more of the bed than the other baby. And that's what the risks are for monochorionic diamniotic multiples, is the concern with shared placenta, and also the the connections and the blood flows between those two. And then the ones that I talked about, the monochorionic monoamniotic. And the risk with these guys is that they're just floating around in the shared swimming pool, and they can twist and turn, and their umbilical cords can become tangled, which can lead to obviously fetal loss. And then conjoined twins, which we're not going to talk about, but those obviously are not. Okay, so here's a case. 39-year-old comes for an 8-week ultrasound. The following ultrasound was performed. So I want you guys to think, what type of pregnancy is this? Okay, just everybody look, and you can answer or talk to yourself. Okay, so I'm going to keep that answer for just another couple of slides. But if we look at chorionicity, so chorionicity means, what is the placenta, as well as, amnionicity, which I'm going to imply. We want to see, look at the number of gestational sacs and embryos, number of amniotic sacs within the chorionic cavity, and also number of yolk sacs. So in terms of number of gestational sacs, each gestational sac forms its own chorion, which becomes a placenta. So if you've got 2 gestational sacs, that's going to be dichorionic twin pregnancies. But if you have a single sac with 2 embryos, that is gestational sac, that is going to be a monochorionic twin. But notice that I'm not talking about whether there is, monochorionic, diamniotic, or monoamniotic. Okay, so it's easy when you have this situation, right? You can see 2 gestational sacs. Definitely here, this is a dichorionic twin. But here, all we can say at this point, because it's 8 weeks, is that it's monochorionic, because I'll show you. Okay. So before 10 weeks, distinct separate amnions may not be seen in monodi twins. And that's because the amnions grow outward from the embryonic disc to form the intertwin membranes after 10 weeks. And these membranes are very thin, and it's easy to be missed by transabdominal ultrasound or an early pregnancy. So it is very common for us, or at MFM, or even in my obstetrics practice, to get a referral for mono twins twins, which again are very high risk, but it's because the ultrasound was too early to determine if there is a membrane. So, here we are at 8-9 weeks-ish. This one, you can see those membranes and it's nice and thin, and you don't have that twin peak sign. So this is monochorionic diamniotic. But this ultrasound is, I think, approximately 6.5 weeks is also monochorionic diamniotic. It's just that you haven't seen that membrane yet. So I'm going to come back with some examples, but just a mention of the yolk sac. It can be used if you're early on trying to help decide if it's a monochorionic monoamniotic versus the diamniotic, but it's not a very reliable sign and it's often missed. It requires later verification. So I think it's better to just say, especially under 10, 11 weeks, to say monochorionic and not to say the amnions, because that should be determined a little bit later. Okay, so here is a report. A twin pregnancy is identified with 2 fetal heart rates. Crown rumps are equivalent to menstrual dating of 11 weeks and 3 days. That is an actual quote from a report I got. So what is missing? Okay, the answer is the chorionicity. Okay, so to me, it's almost like you shouldn't just say there's a twin pregnancy. It's almost like there's 2 different entities, whether you have dichorionic twins, which is really that risk of preterm birth, versus monochorionic twins, where you have many, many risks of pregnancy complications. So after 10 weeks, these are the signs that can help us determine which of these 2 entities we have: placental number, chorionic, twin peak sign, or the lambda sign, characteristics of the membranes. And then later on, after 16 plus weeks, if you see a boy and a girl, then you know that 99.999% chance that, that just confirms dichorionic. And sometimes it's because it is hard to tell. The further along in the pregnancy, you won't be able to see the classic twin peak sign as well. So it really is best to determine chorionicity and amnionicity, in mid-pregnancy. Okay, so number of placentas, there's 1. There's the second placenta. That is easy. It tells us that we have dichorionic twins. However, if you have both placentas on the same side, they can look like one, and that's where we have to look for the twin peak sign. Okay, so here we go. So we have both posterior placentas for both twins, but you can see right here that sort of wedge. That's the twin peak sign or the lambda sign. And remember that really you have 4 layers here. You have 2 chorions and 2 amnions, and there's a space there in between that allows the villi to grow, so that potential space, so you get that sort of wedged appearance. Unlike the monochorionic twins, where you just have the 2 amnions fused together, so that you get that T sign, or that's basically just that. There's the T, so there's the horizontal line and the vertical line, and you do that that has to be assessed at the placenta surface. Okay. All right. Membrane characteristics. This helps you decide as well, because there is thicker layers in the dichorionic twins. You can see it here versus that thin, almost spidery website for monochorionic twins, diamniotic twins. And so I don't know if I can emphasize this more. Why is it essential that we need to confirm the chorionicity? Because there's different and more severe problems with monochorionic twins, and a late diagnosis might mean not identifying twin-to-twin transfusion syndrome, and that could lead to a preventable fetal loss. So also how we manage anomalies, because there's shared circulations with monochorionic twins. If we do have one baby that has a very severe birth defect, the option of a selective termination is much more challenging. How we screen for aneuploidy like Down syndrome or trisomy 13-18. Determining what's the cause of growth problems for a baby, it is different if you have a shared placenta versus 2. And if you do have a demise, how that pregnancy is managed as well. And also delivery planning, because we deliver monochorionic twins earlier. So here's a case, 39 years old. She is having a dating scan at 7 weeks and 4 days. This is her first ultrasound and a spontaneous pregnancy. And this is a patient of mine. When I give these cases, I usually am giving patients, giving you examples of my own patients. So they do, they're not just random people. Again, these are, or random images. These are people attached to that and stories attached to their images. So they say A and B, and again, you're supposed to say 1 and 2, but everybody says A and B still. And this and this is from, notice the due date. This was not a while ago. This was last year. Live monochorionic, monoamniotic gestation. But remember what I said, under 10 weeks, you can't determine for sure if it's monoamniotic. There actually is, if you looked up close, there was a membrane there. But she went back for ultrasound at 12 weeks and 2 days for her nuchal translucency assessment. And you can see a nuchal translucency here of, sorry, I have my screen share, 2.8 millimeters. And the second baby had, and again, technically difficult, but a nuchal of 5 millimeters. So quite discordant. So aneuploidy screening, because monochorionic twins are always identical twins, they should have the same genetics and the same DNA. Therefore, they have the same risk of Down syndrome, of aneuploidy, so, the trisomies. So whereas dizygotic twins, those two babies that are in their each bed with their own blanket, they're separate, they're fraternal twins, they're just siblings that are sharing a womb, womb mates, and therefore you calculate the risk as separate for each baby, so they're different. Okay, so when you actually see a discordance of the nuchals in monochorionic twins, when they're more than 20%, this actually is a indicator or red flags for pregnancy complications. And most of those are related to the fact, again, that these babies share a placenta, which means they have shared blood supply between vessels. And the most one that you're most likely aware of is that twin-to-twin transfusion syndrome, for which there's a 10 to 15% chance with these monochorionic twins, but also selective IUGR, where there's unequal placental sharing, and one baby is not growing well, whereas the other baby is. In addition, you may see it when there is discordance for anomalies. So one baby may have a cardiac, congenital cardiac condition, for example, or it could just be that you have both normal fetuses and there's measurement issues. You could have a situation where both babies have aneuploidy, or only one baby does, would be very, very rare. So, okay. So unfortunately for this poor mom, this lovely mom who'd had multiple pregnancies losses, she went back at 14 weeks, and both twins, there was no fetal heart rate, and this was absolutely devastating for her. I would like you to know that she is currently pregnant, and she is 24-ish weeks with one baby and doing well, but obviously highly traumatized from what happened in her last pregnancy, the twin one. So just shout out to remember that when she was having scans in this current pregnancy, how stressful each ultrasound was, given what happened before. So to recognize that and to really just be empathetic. Okay, so here is a 9-week gestational age twin gestation diagnosed at a first trimester viability ultrasound for uncertain dates. Okay, so this is not my own image, but in this particular case, a little bit further along, but they're very close together. We know that they're monochorionic. And then subsequently, we found out they were also monoamniotic. That means they share a sac, and the risk of cord entanglement is very high. Traditionally, we said there was up to a 50% mortality with these babies, but with aggressive monitoring and delivery, and we usually deliver between 32 and 34 weeks, the loss rate is much lower, closer to 10%. Okay, and how do we know for sure that these are those mono twins? Well, as I said, you can't determine it in the early part of pregnancy, so really it should be over, ideally, definitely over 10 weeks, but in some cases, depending on how well the mom scans or how not well she does might be even a little bit later. We do not see an intertwin membrane. You see, and again, the yolk sac is not a great sign, but theoretically, there would be a, you might hear my dog in the background, I apologize. But no intertwin membrane is seen. You do see a single placenta, but the gold standard of being able to diagnose these twins is from entanglement of the umbilical cords. And this is what it looks like. This is a cord knot, and you can see it on ultrasound as well. Okay. It's tough when it's a virtual presentation because I can't look at people's faces and see if they seem confused or bored. So I'm just going to assume you guys are all riveted and paying attention. So 28-year-old G3P2 sent for ultrasound at 15 weeks. Now this time, remember, she's over 10 weeks gestation. The report said monochorionic, monoamniotic twin gestation. I'm just going to mute myself to yell at my dog. One second. Okay. And what we see here, you can see a lot of amniotic fluid. We don't see a membrane. We see twin B and we see twin A. Okay, which should be 1 and 2. But there seems to be a lot of amniotic fluid surrounding twin A, and the deepest vertical pocket was 11 centimeters. And you can see a full bladder on this baby. But then when we looked more closely on the second baby, it wasn't, there is actually a membrane, see? And there is a pocket of fluid, but it's very small, and we could not identify a bladder. So what is the diagnosis? And again, I'm not going to be looking at the chat box, but I'm going to give you a couple of seconds. And before we get to the answer, which will be potentially one of these, the absence of an intertwin membrane. You know, they say greater than 8, but I'm going to change that to greater than 10. It could be a monoamniotic twin pregnancy, but really have to think more commonly, it's more likely that you have one baby that has oligohydramnios or the stuck twin. Most commonly, that would be due to twin-to-twin transfusion syndrome, which is what we saw in this case. And that's not diagnosed just by the stuck twin, but also the fact the other baby had polyhydramnios. So it's the polyhydramnios and the oligohydramnios that's needed for that diagnosis. You could have rupture membranes of one baby, or you could have one baby that's not producing amniotic fluid due to kidney problems. So there again, this is a case of TTTS. You see polyhydramnios, you see oligohydramnios. You can actually see that the amniotic fluid of that baby is more echogenic as well. And why we want to have that diagnosis is that there is interventions, and as Nimra mentioned this morning, you know, in her center, it's a fetal therapy center at Mount Sinai in Toronto, and certainly, you know, they do laser ablation of the little blood vessels that are the cause in that placenta. Okay, it happens in 10 to 15% of all of these twins, so not uncommon. Imbalance in the net flow of the blood across the placenta. So basically what happens is one baby, you know, has dominance, we call the donor, and the other is a recipient, and defined by poly and ollie, okay? And again, the poly with the other babies, really important. And different stages. So poly-ollie is by definition TTDS, absent bladder in the donor. So this particular baby had stage 2, abnormal Dopplers, high drops, or death of one or both babies. So again, why it's important that you can tell us, the obstetricians or the MFMs, what type of twins these are, and be able to recognize the complications that go with monochorionic twins, because they do need to be monitored by a high-risk pregnancy center. You know, our goal with rural telemedicine is that we can have a balance between having monochorionic twins, having scans in closer to home, and as well in a combination with urban MFM sites. But there definitely has to be someone overseeing all of this. TAPS is an interesting one. It's sort of like a type of twin-to-twin, but in this case, it happens later in pregnancy, and you get one baby that becomes anemic, and one baby that has is polycythemic. So when you're at birth, you might see a very pale baby and then a very pink baby. And it's a little bit less common, but you do see it more often after twin-to-twin transfusion syndrome. And we can monitor that by looking for signs of anemia in one baby, very discordant middle cerebral artery Doppler, peaks systolic velocities, which tell us about fetal anemia. Okay, I know that we are tight on time, and I apologize for speaking quickly. Congenital anomalies, it's the same for dichorionic twins, but if you have monochorionic twins, the fact that they were once one egg, one sperm, and they split, that is a teratogenic event, meaning just that process increases the risk of structural anomalies. They can include spine here. This is a meningomyelocele or cardiac. That is tetralogy of Fallot. You can see your VSD and your overriding aorta as well. Preterm birth screening in twins. As I said, those babies, regardless of whether they share a bed or they don't, they like to come out early. It is a huge source of, well, not source, but if you were to open the doors of the FMC Foothills Hospital where I work in the NICU, you're going to see that there is an excessive dominance of preterm multiples that are there. The average age of twins being delivered is about 35 to 36 weeks. Under 32 weeks is where we really see the higher risk of newborn premature birth complications, and that happens up to 12% with twins. So cervical length, which my lovely colleague Lisa is going to discuss with you, same criteria, same method for measuring cervical length, and if the cervix is short, she needs to be referred, and depending on the management, could be a cerclage or progesterone or surveillance. Okay, and just a quick mention about surveillance. So monochorionic twins, remember they share a placenta, high risk of growth problems with one of the babies and consequences. They need to pretty much have ultrasounds every 2 weeks, starting at about 15 to 16 weeks when we first can see evidence of TTTS. Dichorionic twins, they have a higher risk of growth issues in the 3rd trimester. So certainly, we increase surveillance after 28 weeks, but you really don't need to do as frequent ultrasounds, and I do not do every 2-week ultrasounds for these babies. Discordance, meaning a difference between babies greater than 20% for estimated fetal weight, or abdominal circumference greater than 20 millimeters. But if you have dichorionic twins where one is a boy and one is a girl and they're both growing well, and one is actually on the 90th percentile and one is on the 60th percentile, it's probably not of any clinical significance other than for delivery. And that's just, sorry to go back to say, monochorionics every 2 weeks, dichorionics every 4 weeks, starting mid-pregnancy. For delivery thoughts, monochorionic twins do have a higher risk of stillbirth, and like it or not, it is quite significant. So we do deliver those babies around 36 to 37 weeks, with dichorionic twins about 38 weeks. There's some other interesting anomalies that we see with twins, the conjoined or the trap sequence. Again, those are a little bit more rare. But in terms of delivery, that's me. There we go. What we want to know is the fetal position, the fetal size, and any discrepancy between the twins and placental positions. Because if our second baby is breech, that's okay for vaginal delivery, but if it's significantly bigger than the other baby, then we might want to move with a C-section. This picture here, that actually is conjoined twins, very rare. And this is another complication of monochorionic twins, and that's the trap sequence or the acardiac twin. So you basically have one baby that's normal, a second baby that does not have a heart, and therefore would have been a demise in a singleton pregnancy. But essentially, one baby's heart acts as the heart for two, and as a result, you have an acardiac twin that is kept essentially alive by its pump twin, and that results in a high chance of high drops and fetal loss for the baby. That heart has to work twice as hard. Okay, when a baby dies, a twin, if it's a dichorionic twin, it's absolutely tragic and terrible. But if it's a monochorionic twin, it's even more complicated, because if you lose one baby, there can be a sudden drop in blood pressure causing hypotension, anemia, ischemia, and brain injury. So you have a chance up to 30% of death or neurological injury, which could be highly significant for the survivor twin. Okay. So I'm not going to talk about higher multiples. other than to say they're there, and please refer them early because there is a discussion that has to be made about potential multifetal reduction. And I'm just going to finish off. I got interviewed to give a comment on how common it would be to deliver 3 sets of twins in 4 years for this family who lives near Regina, Saskatchewan, and they were all spontaneous. They were not assisted reproduction meds or IVF. And all I can say, yeah, if you guys are tired with the conference already, imagine how this family feels right now. So, okay. So just a summary, please, please, please report and identify and think about and understand the significance of dichorionic versus monochorionic. You can defer decisions about amnionicity till after 10 weeks, and monochorionic twins are high risk of complications. Refer to MFM and beware the non-visualized membrane. Greater than 14 weeks, do your cervical ultrasounds and growth stuff. Thank you. Okay, I think I am done. Dr. Obi, hit me up.
Hello, Dr. Cooper. Thank you so much for that great talk. We do have some questions on the chat here, and I'm going to just get going with some of them. So some of the questions we have here are, can you have mono twins with 2 yolk sacs?
Sorry, I am just having a video issue. No, I mean, you can never say never because weird things happen, but embryologically, no, you should not have 2 yolk sacs. So maybe you're seeing some other structure. Oh, sorry, Dr. Obi, I can't hear you.
Sorry. Yeah, no worries. We're saying, why can't we say twin A or B anymore and have to say fetus 1 or 2? And I'll combine that with another question. The other question too was asking, please confirm we should keep the first twin as first twin and second twin as second twin to follow growth, not maintaining twin A as the presenting twin on each exam. So those are 2 questions combined.
Yes, so I'll take the second one first. Yeah, as I said earlier, that's correct, that if you have designated whatever fetus is the one that is closest to the gestational sac, that is closest to the cervix, the most inferior, that will always be fetus 1, even if that baby is no longer the first baby. So say it's 12 weeks or nuchal scan, you have the most inferior fetus is, you determine is fetus 1, that baby has an anterior placenta, the other one has a posterior, but then lo and behold, 4 weeks later, you find out that based on the placentas, that baby is now actually higher than the other one. You're still going to call each baby what you first determined them to be, but clarify in the report by saying which baby is presenting. So you could say fetus 1 is trailing, or fetus 1 is presenting, and that's again to follow growth. Why did we no longer call it A and B? This is based on ISAWOG, so the international group as well, that sort of had a statement to say that to use a numerical value instead. And I'm not exactly sure of the specific logic of it, and if anybody does, feel free to put it in the chat. But basically, it's just, again, back to the idea that we want standardization so that we all speak the same language when it comes to obstetrical ultrasound.
Excellent. Thank you very much. So the next question says, is there a numeric value we can use to differentiate the T sign, meaning the monochorionic membrane for MCDA twins versus the lambda sign? And she's asking if it, or the person is asking if it's 2 millimeters, you know, the distance or thickness of the membrane, whether they can use that to differentiate.
Yeah, there's always people who will try and objectify things to put numbers on it. And I would question if, I'm sure there are papers that would suggest that if they are actually validated, most often it is subjective. And I know that our practice has been not to use specific measurements, but to use the subjective appearance of the lambda versus the T.
And I would agree with that because there are a number of factors that contribute to the chorionicity. So it's better to use all the information, not just one single measurement. Now, the other question is, which Dopplers should you recommend routinely for every 2 weeks follow-up of MCDA twins that have no signs of growth discordance or bladder size discordance or amniotic fluid discordance? And,
sorry.
And then I'm going to add that on, when doing MCDA twin biophysicals, any tips or recommendations on where to take the Dopplers, close to the baby, things like that. So 2 questions.
Yeah, so when you have, if you have monochorionic twins who are growing well, you're not doing Dopplers for, you're not doing the umbilical artery Doppler. You're not doing the middle cerebral artery Doppler PI, looking for brain sparing, et cetera, if they're growing well and they're concordant. However, TAPS that I mentioned, the pink baby and the pale baby, that is for fetal anemia. So that is looking at the middle cerebral artery Doppler, not the umbilical artery Doppler. And that is looking at the peak systolic velocity as an indicator of anemia. So it's a different use of Dopplers. So if we were to use umbilical artery Doppler, say that we do see growth discordance or we are seeing a fall off in fetal growth, then when you are using the umbilical artery, it's always best to do a free loop. And Dopplers are not perfect. I think that you really do, and I have seen variability in Dopplers for sure. Make sure that you really do multiple readings. Make sure that you adjust your gait appropriately, that you do have a nice free loop of cord, and that you're not sampling multiple vessels, because it can, and to use your filters as well, you really want to recognize the impact that improperly performed Dopplers could result in either a miss of an adverse outcome or an unnecessary intervention.
Thank you very much. And I would add that when we're talking about the Dopplers, we're doing the Dopplers, we are referring to centers that have already trained or are in collaboration with MFM to do these Dopplers so that there's appropriate interpretation. Another question is, if twins have discordant growth with 2 different EDC dates, which date do you prefer to use?
Okay. Yeah, so they shouldn't have different EDCs. You date a pregnancy based on the bigger CRL of the fetus in the first trimester.
Okay. And the last question we have here is, how can twin 1 and 2 switch?
Yeah, so it's less common with dichorionic twins for sure. And monochorionic twins, you can see it if they're both sort of close together and you've got 2 heads, for example, or maybe, you've got a head and feet. So, it's not necessarily that they're switching, it's about which parts are the lowest. So if you got a head here and we're calling baby A the one that's head first, but then, the baby B is here with their feet, let's say it's footling breech, and then they push their feet down, then now this is the presenting twin, even though that's baby 2, if that makes sense.
And I don't know, Steph, what you think, but I think later on in gestation, sometimes right and left helps.
Yeah.
It's hard when they're on top of each other. That's sometimes confusing, but knowing who's right and left often helps.
Yeah.
Earlier in gestation, they might switch, but later on they tend to stay, I think, most of the time, right?
Yeah, for sure. And depending if amniotic fluid and multiparity. But it is, I do use ultrasound in my office a lot for twins. I don't even do just heartbeats alone because I do look at position. And it's interesting, moms actually will be able to identify which baby is which themselves from fetal movement. So they get used, but I use the ultrasound to help to say, oh yeah, that's this baby's movement and that's that baby movement as well.
Okay, well, thank you very much.
Excellent.
That's about it with the questions. Thank you.